Hi, thanks for a great presentation, and I admire your optimism, and I assume with the metaphor of Elastigirl, that it's important to be flexible in this kind of work. My name is Dave Brent. I'm a member of the forum, and I was wondering to what extent you think there's an opportunity to look at variation in practice across states as a natural experiment. It seems like what you're trying to do is look more within states, and you shouldn't compare states, but I'm wondering if there is an opportunity to do some of those kind of things.
So are you talking about, I just want to be clear, you're talking about variation in practice between states?
Yes, with the same outcome. That, for example, there may be a difference of opinion about, what's the best type of policy to get a particular outcome, and state A does this and state B does that. It would be, it could be a natural experiment.
So that actually, if I was unclear, I should clarify that. That is actually, I think, what most of what we do is to look at variation in practice. So for the early elective delivery, for example, all of our states have different ways of enforcing a hard stop policy, and we try to see, is there a difference? And states were given 6 months or even maybe a little longer ago, given back their data about how they compared to all their peer states so they could see where they're at. Okay. So we do look at the variation. My point about looking deeper underneath that was the opportunity to use those same measures to vertically align so that hospital A could maybe look at how they compare to hospital B. But fundamentally, we look at the Medicaid Medical Director level, are looking at how state policies impact state practice.
Thank you.
Hi, thank you for this. I'm Kimberly Hoagwood. I'm from NYU and a member of the forum. I was very interested in what you talked about with respect to patient-reported outcomes and how important that is as a construct. In our field of children's mental health, that largely means parents. And yet, from a measurement development, I think that's our weakest area, frankly. There are some parent reports of satisfaction which don't correlate with outcomes. There's family report of impact or burden, but that's a pretty blunt instrument. So I wonder if you could say a little bit more about where you see the need for development of patient-reported outcomes, the ways in which that might happen, and particularly with respect to families and kids.
Boy, that's a big topic.
You're welcome.
I guess just a couple things. You guys are way more expert perhaps than I am on some of this, but I think that we look at patient satisfaction or patient report as the be-all and end-all sometimes, and I think that we have to get past that. And so I think that and I think the example that came to mind while you were asking the question was about something that's related to this but not directly, chronic pain. We look at chronic pain, we look at whether people have decreased pain. Well, that's a pretty ineffective measure, but we need to look at functional status. So then the question is, how do we look at functional status? In this population, functional status may be school days missed, or outcomes for school. The other thing I just want to say about that, so that may be one thing. The other thing I want to say is we have the opportunity to get out of the dark ages about patient-reported outcomes. And I sit there and go, all of us will sometime in the next 15 minutes look at our cell phones, and use them for something just to see if somebody talked to us. We can use cell phones for surveys. We can use cell phones for a survey every day about something so we can tell what's going on in somebody's life. And there's actually technology vendors who are kind of anxious to do that with us. So we have to start thinking about different modalities of doing patient-reported outcomes, and then not just look at patient-reported satisfaction or patient-reported well-being, but how people are actually functioning in their families and in their communities.
Well, thank you for the great talk, and I guess mine might be more of a comment and maybe a question, but I wanted to alert folks that CDC is actually working closely with a couple of states, with the National Association of State Mental Health Program Directors in Vermont, and with SAMHSA and HRSA, because we identify this lack of capacity around understanding data and utilizing data and bringing multiple sectors together at the state level. So we're actually going to place epidemiologists to focus on children's mental health issues to work closely across sectors within the state as a proof of concept. We've done some work in Missouri, doing some work in Georgia, and work in Vermont, but hopefully that will serve as a model. And the key to it is that you have a lot of people who are dedicated and wanting to do that, that these federal agencies are providing the resources, both in terms of fiscal resources, but expertise, but then also focusing on a particular issue, and it came about around ADHD. So have a target and saying, how can we better understand the diagnostic and treatment policies around ADHD, and then how do we prioritize the work that we're doing? So I just wanted to let folks know that it is doable, there are things out there, and that we need to share more of that information.
Thanks. If I can make a comment to your comment, and that's that the technical sides of this we can't ignore, because the data sharing, the definitions, all those things are what really kind of get in the way sometimes, and I think that states need help with those kind of things. Okay.
Hi, Jennifer Nandu with the Robert Wood Johnson Foundation and a member of the forum. My question actually builds off the last question, which is looking at sort of the front end of this work and the back end of this work. In both the previous panel and your comments, you really talked about sort of the relational issues that actually lead to the collaboration. And so one question is how philanthropy, in addition to funding, can support efforts and help to stimulate that collaboration through the grant making. The second question is around the data utilization and the fact that, particularly with respect to policies, people misinterpreting the data. And my example would be for children experiencing trauma or mental health issues related to adversity, for instance, often their trauma actually being an implication for them staying longer in systems such as juvenile justice or child welfare, because people see that as something that's a deficit, as opposed to linking them with systems that help. So if you can comment on sort of that, the issues of the implications of how we use the data.
Well, let me comment on your second one first, and I think your second one gets at the issue of are children's mental health issues a diagnosis and pathology, or are they a social system issue? And and I think that we have this opportunity because Medicaid is now paying for so much more of the health care that we need to start thinking of them as a population health social system issue. The thing that always comes to mind, I have to put this in here just for a sec, is we have hepatitis C drugs that cost over $100,000 a pop. Many people know this. For over $100,000 a pop, we're treating an effect of bad social systems that lead mostly to addiction to IV drug use. And I'm sitting there going, wow, we could send a lot of people to college for that amount of money or something else. So the fact that it all costs so much on our end and that we're seeing it on the population health end make that an option. So I think we have to really figure out this juncture of diagnosis and what we call diagnosis and what's actually sort of trauma. And then to your other thing about how to do this without just throwing money at it, which I totally concur with, is convening, I guess, is the first thing that comes to mind. And that if we can get if somebody was going to say, let's get all the Medicaid data folks who are looking at children's mental health issues in the same phone calls once a month, and say, let's compare the data, let's talk about that with relationship to a goal and a project, I think you'd have not a presentation about something that's happening at the federal or a different state level, but a working group to say, how are you going to define ADHD? What are your parameters? Who's making the diagnosis? What questions do you want to ask? I think you'd get far in just getting people's opinions who actually are working with the data. 21 seconds. Do you want to do one more question? Okay.
I'm David Hawkins. I'm a member of the forum. I really love your idea of state-led national projects. I think it's just a wonderful idea, and it's great to see what you've done. I also want to come back to this question about patient-reported outcomes, and actually it's kind of a larger question for you and Bob George and the people on the first panel as well. A number of states actually collect surveys. They do surveys of adolescents in schools that provide self-report data on a whole number of risk and protective factors that have been experienced by young people, as well as self-reports of behavioral and mental health and other kinds of outcomes. And I'm wondering the extent to which those kind of data that are collected by states and available at least at local school building levels are integrated into these data systems that you're talking about, as well as Bob George and others are talking about, as we talk about integrating data systems. How much are we including data from things like the YRBS from CDC or the state survey that is conducted in many states of young people and their health?
So I can only speak to Minnesota, and I think we don't have a formal way to integrate the BR, FSS, that stuff. We do have with regard to the parents, we do have the risk survey for pregnancy. I'm blocking on the name of it right now. It'll come to me. Pardon me? PRAMS. We do have PRAMS, and PRAMS, the difference is that PRAMS is actually patient-level data you can integrate and look at, and so we do use that. The BRFSS, so there's no standard way to do that I know that states are using that, and that brings up this fascinating challenge. Medicaid, state Medicaid programs and CDC are working closer together than we ever have, so that's good. We have ways to go.
So just a quick question. I actually have a lot of questions, but just a quick one. I'm intrigued by your idea about looking at autism treatment outcome. I'm Andy Schiff from Autism
I'm sorry,
Speaks,
I didn't hear what you said.
Andy Schiff from Autism Speaks, member of the forum.
Okay.
I'm intrigued by your idea about looking at autism treatment and outcome.
Right.
Using your efforts here, the data you're generating. What are the potential implications of a difference insurance coverage laws across states on such an effort?
So I guess the quick answer is that CMS put out a guidance to states that autism early intensive intervention is an EPSDT covered service. So the question then becomes, how are states implementing that? And I guess that will be, the reason why early elective deliveries is easy and autism is hard is because the diagnosis of autism is variable and difficult to make. The treatments are variable and the outcomes are hard too. No big deals there, right? So I think that we're actually in the process of looking at how to sort of classify those as best as possible. But other states, if we could do that across states, that would be a worthwhile thing. And the coverage, I would say maybe the coverage would be secondary to knowing what individual treatments the kids have, and we could say, well, in this state, they cover this for this population, so let's just lump them in the category of kids who have significant defects of social emotional behavior in the preschool age range that are going to get this level of therapy, and maybe be a little agnostic to what take the state coverage for where it's at.
Thank you.
Thank you.
Thank you.